Imagine stepping into an operating theater. Not like today, obviously, with all the gleaming tech. No, picture this. Your main tools are, well, a candle and a mirror. That sounds almost impossible, doesn't it? Maybe something from a medical history museum. Yet that's actually where the incredible story, the real odyssey of the laparoscopic machine truly kicks off. So in this deep dive, we're going on that journey. We're calling it the odyssey of laparoscopic surgery. Our mission really is to trace how that machine you use every day, the tower with the light, the screen, the pressure, controls how it evolved from those, frankly, rudimentary gadgets. And for you, as surgeons, especially those maybe earlier in your laparoscopic journey, understanding this evolution, well, it isn't just history for history's sake. It's about really getting the ingenuity behind it all, the courage, the sheer persistence that shape the tools you hold now. It adds context, right? It makes you appreciate the foundation of your practice and maybe even see where things are headed next. Think of it as a shortcut to being really well informed about the core of minimally invasive surgery.
Yeah.
Okay, let's rewind. Way back.
Early 1800s, medicine looked, well, very different. Our story really starts with a German physician, Philip Bozzini, and he had this idea that was honestly pretty audacious for the time, maybe even heretical. He invented something called a Lichtleiter, literally a light conductor. Now, when we say light conductor, we mean basic, really basic, candles and mirrors, that was it. And his goal, to actually look inside natural body openings. Can you just picture the nerve, the thinking outside the box required back then? Is basically trying to shine a candle into the darkness, wasn't it?
It really was. And you have to put it in the context of the time, the early 19th century. The absolute dogma among surgeons then was crystal clear. If you wanted to see inside the body, you made a big cut, an open incision. That was it, period.
Yeah.
So Bozzini, with his, simple curiosity, just wanting to look without that big incision, he was directly challenging everything. And the reaction wasn't exactly welcoming.
No kidding.
The Vienna Medical Society, they didn't just disagree, they basically ridiculed him. Our sources say he was dismissed for fooling around with gadgets.
Wow. Fooling around with gadgets.
Yeah, it just captures the disdain, doesn't it? It shows how threatening a really new idea can be. But even with that dismissal, he planted a seed, a critical one, the very idea that you could visualize internally, however crudely. And that seed, well, it took a while, but it eventually grew. It's a lesson, isn't it? Revolutionary ideas often get shot down first.
Right. So that first spark from Bozzini, even though it got laughed at, it didn't completely die out. Let's jump forward now, nearly a century later, early 1900s. This is where we see the direct line to modern laparoscopy really start. We meet Georg Kelling, another German surgeon, and he does what many consider the first true laparoscopy, although he called it celioscopy. But what made his work so important? Well, first, he didn't start with humans. Probably a good idea back then.
Definitely a good call.
He used a cystoscope, a tool already sort of in use for looking in the bladder, but he used it to look inside a dog's abdomen. And here's the crucial bit. He pumped in filtered air to create space, what we now call pneumoperitoneum. That space let him actually see things between the organs and the abdominal wall. Just revolutionary thinking, even if, like Bozzini, people didn't really get it at first.
You nailed it. Kelling's genius was that combination. Taking an existing tool, the cystoscope, and adding that totally new technique, insufflation with air, those two ideas, they're still the absolute bedrock of laparoscopy today. Creating a space and putting a scope in to see, he proved you could get a view inside without a massive incision. I mean, think about the challenges. Sterility, filtering the air, the risk of putting in too much air with 1900s tech.
Yeah, it sounds incredibly risky.
It was a tightrope walk, for sure, but the records show, just like Bozzini, the world didn't take him seriously. It's that pattern again, isn't it? Radical idea, initial resistance. It's a good reminder for any surgeon today thinking about new techniques. You often face that uphill battle first.
Okay, so Bozzini had the concept. Kelling showed it could work in an animal. The next logical step, the big one, was trying it in humans. And that step was taken soon after Kelling by Hans Christian Jacobaeus, a Swedish physician. He was the one who took that brave leap. Picture it, Jacobaeus using air, using those early cystoscopes on tuberculosis patients, often looking at the lining of the chest or abdomen. The descriptions from the time are so vivid, they called them the cavemen of laparoscopy, playing with fire in a dark cave. Really paints a picture of how primitive and dangerous it must have felt.
And that immediately begs the question, right, what drove them? What drove Jacobaeus to take those kinds of risks with human patients, given the tools he had? The answer really lies in how limited diagnostics were back then. Remember, no CT scans, no MRI, not even widespread ultrasound yet. X-rays were still pretty new for soft tissue.
Right, they just couldn't see inside easily.
Exactly. So the ability to get any direct look inside, even a crude one, was potentially huge for diagnosis, especially for something like TB affecting the pleura or peritoneum. Getting a look, maybe even a small biopsy, that was incredibly valuable, even with the risks. So Jacobase's work, yeah, primitive by our standards, but it shows immense courage, that pioneering drive to just understand disease better, even when the tools were barely up to the task.
For you, listening now as a surgeon, this early period isn't just, trivia. It really marks that huge mental shift. From seeing inside means cutting wide open to the very first incredibly cautious steps towards just viewing through a small hole. It sets the whole foundation for everything that followed. It showed that vision without the big incision was worth chasing. It's about that curiosity, that courage still driving us today. Okay, let's move into the mid-20th century. That dim light we talked about, the candle and the early bulbs, it starts to get a bit brighter, slowly but surely. Technology finally starts catching up, thankfully. Those flickering candles Bizzini used, replaced by incandescent bulbs. Better, but still not perfect.
Still hot. Right?
Exactly, still generated heat. But then came a real breakthrough. Fiber optics. Now, you use fiber optics all the time, but think about the impact then. These thin glass strands could bend light from an external source right into the abdomen. Game changer. Because now you had brighter light, and crucially cold light. No more bringing the heat source right inside.
No more risk of actually burning tissue with the light bulb itself.
Yeah.
Yeah, that cold light distinction is absolutely key. Those incandescent bulbs, they got hot right at the tip of the scope, putting that heat inside someone, big worry. Potential burns, sure, but also just heat haze, fogging up the view, maybe causing adhesions later.
Right.
Fiber optics fix that. Light comes from outside, travels down the fibers, much safer, much brighter, much more effective. It meant surgeons could look for longer, see more clearly with less risk. It made the whole thing much more practical for, regular use.
Building on that safer light, the 1960s brought another massive jump in optics. This really changed what surgeons could actually see, the Hopkins rod lens system. For anyone who values a clear view, which is every surgeon, this is where it gets really interesting. This system just completely transformed image quality. No more yellowish shadows or vague outlines. Suddenly you had crisp details. Imagine going from a blurry photo to HD overnight. That kind of leap.
So why was this so crucial? From a practical standpoint, before Hopkins, endoscope optics were pretty basic. Narrow view, dim, often distorted at the edges, made precise diagnosis really tough.
Hard to tell what you're looking at.
Exactly. The Hopkins system, using these precisely arranged glass rods and air gaps, dramatically widened the field of view, let much more light through, and boosted the resolution. That better image quality meant surgeons could finally see anatomical details clearly enough to be confident. It shifted laparoscopy from just seeing if there was a big mass to actually examining things in detail, identifying smaller problems, seeing subtle changes. That clarity was indispensable.
Okay, so now we have better light, better cameras, better optics, not cameras yet. With this clearer view, surgeons started using laparoscopy more, but mainly for diagnosis. It really took off in gynecology, didn't it? Looking for endometriosis, PID, figuring out infertility.
And liver biopsies, too, looking at the peritoneum, general inspection.
And this is key for this period, still mostly diagnostic. Looking, assessing, but not really operating in a major therapeutic way yet.
Right. And that diagnostic era, looking back, was absolutely vital. It was like the necessary training ground. It wasn't just about looking. Surgeons were learning what anatomy looked like through a scope in 2D in that confined space.
Getting used to the view.
Exactly. Building familiarity, getting confident moving instruments around without direct touch, developing that hand-eye coordination. That whole period built the skills and the confidence needed for the next big jump into actually operating laparoscopically. Without that groundwork, the therapeutic revolution couldn't have happened.
Now, even with better light and optics, let's be real, the machines back then were still pretty clunky compared to today. Surgeons were juggling all these separate bits. Bulky light cables, tubes for suction, irrigation, and the insufflation. Primitive doesn't even cover it.
Oh, yeah.
Often just coeuros from a pressure bottle you had to manually crack open, or sometimes even just a rubber bulb someone squeezed.
Like a blood pressure cuff bulb, basically.
Right. No fancy alarms, no pressure sensors, no digital displays. It sounds intense and maybe a bit scary.
That description really captures it. The sheer manual skill, the improvisation, the intuition required back then. It really was more art than science. Huge variations between surgeons based on their feel for it. And the lack of controlled insufflation. Big safety risks. Trying to keep that pneumoperitoneum stable with a hand bulb. Wow.
Yeah, incredible pressure on the person managing that.
Absolutely. It highlights the raw talent and resilience of those early pioneers. Makes you really appreciate the safety and control we have now with modern towers.
So next time you're doing a lap call or an API, just remember that crystal clear view, that stable pneumoperitoneum, the whole predictable setup you rely on, that didn't just happen. It was earned, built slowly, piece by painstaking piece, from those really challenging diagnostic days. Your practice stands on their shoulders. Okay, fast forward to the 1980s. This is where things really accelerate. The ascent towards the modern laparoscopic tower truly begins. It felt like a lot of things clicked into place during this decade. Two huge technological leaps really stand out. First, high-intensity xenon light sources became widespread. These things could light up the peritoneal cavity like daylight. Just brilliant white light.
Huge difference in clarity.
Absolutely. And second, co-urus insufflators got way smarter and safer. We started seeing proper flow regulators, pressure sensors, alarms, real control.
And that combination was just so powerful. The bright white xenon light, unprecedented clarity, true colors, better depth perception even in 2D. Plus, less eye strain for the surgeon on long cases.
Right. You could actually see subtle differences.
Definitely. But just as critical was that regulated insufflation. Having alarms, automatic flow control. It moved the whole thing away from that risky manual art we talked about.
Yeah.
It became a more controlled, much safer science. That reliable pressure, that stable space. Absolutely essential for safety and for giving surgeons the confidence to actually start operating complex procedures. Without it, the therapeutic leaps just weren't feasible.
But probably the single biggest game changer of the 80s, video cameras. Adding a camera to the endoscope. This was the revolution. Think about it.
Yeah.
Before, it was one surgeon, maybe an assistant, craning their neck, squinting through one eyepiece.
Yeah, a very limited view.
Suddenly, with video, the entire team could see the exact same view, live, on a TV monitor. It opened up the whole operation.
That was the absolute turning point, no question. It transformed laparoscopy from, like you said, a one-man and his scope deal into a real team effort. Surgeon, assistant, scrub nurse, circulating nurse, everyone looking at the same screen.
Everyone's on the same page.
Exactly, which meant better communication, better coordination, much safer procedures. And the impact on training, immense. Residents, fellows, they could finally see exactly what the attending was seeing, learn the steps in real time, made teaching way more effective. It fundamentally changed the OR culture.
Totally. That video monitor is the thing that's completely central to everything we do in lap surgery today. That's a direct legacy of the 80s. It changed how surgery was done, how it was taught, how the whole team experienced it. It made laparoscopy truly ready for prime time, ready for that next big step, widespread therapeutic use. So the late 80s arrive, we've got the video, the better light, the safer insufflation, the stage is set. And this is when we see the first really audacious therapeutic procedures start happening. The big one, the one that really blew the doors open, was laparoscopic cholecystectomy, gallbladder removal. Pioneers like Moret in France, Dubois, Parissat, they just went for it, ventured into totally new territory, and they did it with what we now call incredibly basic gear.
Yeah.
A rigid scope, an early camera, a simple insufflator, and just sheer guts.
Immense courage.
They weren't just doing surgery, they were inventing it on the fly, driven by this idea of a less invasive way.
And you can't overstate the bravery involved there. Challenging the standard open cholecystectomy, that was surgical dogma for generations. Big incision, lots of pain, long recovery. That was just how it was done.
The established way.
Totally. So these guys come along saying they can do it through tiny holes with these, primitive tools. They face huge skepticism, sometimes outright hostility.
I bet.
Imagine trying to convince a senior surgeon you could take out a gallbladder like that. They were operating right on the edge, driven by this vision of less pain, shorter stays, faster recovery for patients. It's that individual belief that can really push things forward.
Yeah, that pushback was real. The reception wasn't exactly warm embraces all around.
Yeah.
There's that famous story about Parissat, right? Presenting his video of a lap col at a big surgical meeting.
Oh, yeah, I know the one.
And supposedly, a bunch of senior surgeons just got up and walked out.
Laughing.
They just couldn't believe gallstones could be removed with such a machine. It sounds dramatic, but it shows the level of disbelief, the resistance they were up against.
And that resistance, looking back, it's almost textbook for disruptive innovations, especially in a field like surgery with such strong traditions. It highlights how ingrained practices become, how skeptical people are of things that seem too different, too radical, especially when it challenges the established hierarchy.
Right. It wasn't just about the technique.
Exactly. It reminds you, progress isn't always smooth. It takes proof. It takes persistence. It takes a real shift in mindset to overcome that inertia. That Parasot story captures it perfectly. You needed thick skin back then.
But then, something unexpected happened. Something really powerful. Despite all the professional skepticism, the ridicule even, lap cold just took off like a rocket. Why? Patient demand? Ordinary people heard about it. Less pain, tiny scars, back to work in a week instead of 6.
The benefits were undeniable.
Yeah, and patients started asking for it, walking into doctors' offices saying, "Doctor, I want the keyhole surgery." That phrase became famous. This pressure from the ground up was huge.
And it raises that fascinating question, just how much power does patient advocacy have, even against medical opinion? In this case, it was arguably the deciding factor. It created this market force that hospitals and surgeons just couldn't ignore.
They had to respond.
They absolutely had to. Patients were demanding it. Suddenly, hospitals had to invest. Those towers with monitors, insufflators, suction irrigation pumps, and electrosurgical units became standard equipment almost overnight. Not just because surgeons wanted them, but because patients insisted. It shows how patient demand can literally reshape medical practice and drive technology adoption. The patient voice was incredibly strong here.
It's such a great reminder, isn't it? Surgical progress isn't just about new gadgets or brilliant surgeons. It's this mix, this confluence of surgical courage, the drive for better outcomes, and sometimes, surprisingly, the informed demands of the public. Every time you do a keyhole procedure now, you're part of that legacy. Built by pioneers, shaped by patients. Okay, into the new millennium, the 2000s. Laparoscopic machines really start getting smarter, more integrated. We moved away from separate carts, tangled wires, towards those modular towers. Everything's stacked neatly together. The monitor, light source, insufflator, ESU, suction recording gear all in one place. It wasn't just tidier, it really changed the workflow.
Oh, absolutely. The impact of that integration was huge, practically speaking. Streamlined the whole OR setup. Faster turnaround times, less clutter, fewer things to trip over or troubleshoot.
Made life easier for the whole team.
Exactly. For you, the surgeon, it means a calmer, more predictable environment, less distraction. You can focus purely on the surgery, not wrestling with equipment. That focus is critical for safety and precision, especially in complex cases.
And alongside the towers, image quality took another massive leap. Digital cameras replaced the old analog ones. Suddenly, the picture was crystal clear. Great color, zoom capabilities, paired with high-definition monitors. You could genuinely see tiny vessels and planes with incredible detail. Going from fuzzy analog to sharp HD must have been amazing for dissection.
And connecting that to practice, that jump in visual fidelity directly impacts precision and safety massively. Being able to clearly see tiny structures, that aberrant vessel, a subtle tissue plane, nerve bundles it, drastically reduces the risk of accidental injury.
Fewer oops moments.
Hopefully. And it allows for much more accurate dissection, more confidence in identifying margins, navigating tricky anatomy. Seeing really is believing, especially when you see with that kind of HD clarity.
Yeah. The insufflators kept getting better too. Really sophisticated. We went from manual control or basic regulators to machines with precise flow sensors, smart algorithms. They could automatically keep the intra-abdominal pressure right where you wanted it, usually 12 to 15 millimil HCG, nice and stable, much safer for the patient.
And why is that precision so vital? 2 key reasons. 1, patient physiology. Minimizes the hit on their heart and lungs. 2, a consistent working space for you.
Right, no sudden collapses of the view.
Exactly. These modern insufflators ensure that pneumoperitoneum is rock solid, minimizes those fluctuations that could obscure your view or compromise safety. It's a background feature we now take for granted, but it's built on decades of refinement.
This whole era, it just brought a level of visual capability that blew surgeons away. There's that great quote, that anecdote you hear. Surgeons who used to squint through foggy eyepieces started joking. We see better inside the abdomen than in the world outside.
It perfectly captures it, doesn't it? That feeling that the technology wasn't just matching human vision, but in some ways exceeding it. The magnification, the bright light, the HD clarity. It lets surgeons perceive details and operate with a precision that was just unimaginable before, even in open surgery sometimes. It's a powerful testament to how tech can enhance our own capabilities, reduce that cognitive load of trying to interpret a poor image.
So that crisp view, that stable environment you expect today, That's the direct result of these 2000s advancements. It gives you the confidence, the precision to do what you do safely and effectively, turning a once foggy challenge into a clear, controlled procedure. All right, moving into the 2010s, the evolution continues. And now we're literally adding new dimensions.
Yes.
3D laparoscopy arrives. This was huge. It brought depth perception back into the minimally invasive world. For the first time since open surgery, you could really sense depth again. Judge how far your instrument tip was, understand spatial relationships intuitively.
A massive change from that flat, 2D view surgeons had adapted to. And the impact, ergonomically and cognitively, was profound. Working in 2D requires constant mental translation, right? Figuring out depth from visual cues alone.
Takes mental energy.
A lot of it. Increases cognitive load, fatigue, potentially errors, especially on long cases. 3D vision, much more intuitive. Better hand-eye coordination almost instantly. Makes complex tasks like suturing feel more natural, less fatigue. It just restored a fundamental part of surgical vision.
And while 3D was emerging, image resolution just kept climbing. 4K Ultra HD cameras started appearing. The clarity became, well, breathtaking. The sources mentioned seeing things like the cystic duct and artery appearing like polished glass threads. Just stunning detail.
And that 4K clarity, the implications go beyond just the immediate view. Think about teaching. Residents can see detail like never before, documentation, crystal clear records. And for you, in the moment, identifying subtle pathology, navigating variations in anatomy, making critical decisions, that extra detail can be crucial. It really elevates the standard.
This decade also saw more digital integration. Things like advanced energy devices, staplers. They started plugging directly into the main tower. Centralized control, settings, feedback, safety checks, all managed digitally through the tower itself. Less clutter again, more control.
So what's the real benefit of that deeper integration? Workflow, for sure. Fewer separate boxes, fewer cables, faster setup. But more importantly, safety. Integrated feedback loops, consistent energy delivery, controlled stapling. The system monitors things, reduces chances for error like wrong settings or misfires. It makes the tower the real command center.
And the digital reach went global too. High-quality recording and real-time streaming became common. Operations could be broadcast across continents. Surgeons could teach, learn, collaborate remotely like never before.
Huge for education and collaboration, right?
Yeah.
Real-time proctoring for surgeons in remote areas, sharing complex cases instantly. It really started to democratize surgical knowledge, breaking down geographical barriers. A surgeon learning a new technique could watch, even interact with, an expert anywhere in the world. Amazing connectivity.
Those immersive views, the precise digital control, the global connection, stuff that would have sounded like pure science fiction to a surgeon in the 80s or even 90s. These tools empower you now to operate with incredible accuracy and confidence and to be part of this worldwide learning community. So where are we headed now? The evolution certainly hasn't stopped. Robotics is a huge part of the current picture. Robotic platforms are essentially integrating the best of laparoscopy, the cameras, the light, the insufflation, into these highly advanced robotic arms. You get wristed instruments mimicking the human hand, incredible dexterity, enhanced 3D vision. It's taking minimally invasive surgery even further. Yeah, robotics takes those core lap principles, minimal invasion, enhanced vision, and just amplifies them. Adds almost superhuman precision, those wristed instruments. They overcome the rigidity of standard lap tools, the enhanced 3D, the tremor filtering, motion scaling. It all improves dexterity, reduces fatigue, lets you do things that were incredibly difficult or impossible before. It's pushing the boundaries of minimally invasive technique. And looking even further out, the next big frontier seems to be artificial intelligence. AI integrated into the machines themselves. Imagine the system warning you, careful, you're close to the bile duct, or automatically tweaking insufflation or suction based on what's happening in the field.
It sounds futuristic, but it's happening. Research is moving fast, and the implications are massive, aren't they? What happens when the machine becomes a smart assistant? AI promises to boost safety and efficiency, providing real-time guidance, analyzing images, maybe predicting problems before they happen, like an intelligent co-pilot in the OR.
Highlighting critical stressors you might miss.
Exactly. Augmented reality overlays, tissue identification. The potential is huge. Of course, there are ethical questions, too, about autonomy and responsibility, but the potential to reduce error and optimize surgery is immense. The machine becomes an active participant.
There's another really important future direction, too. Accessibility. Making this technology available more widely. We're starting to see development of portable units. Think briefcase-sized towers for field hospitals, remote clinics, low-resource settings.
And that's incredibly important for global health equity, isn't it? taking advanced surgical techniques, which have mostly been stuck in big, wealthy hospitals, and bringing them to underserved areas, remote communities, humanitarian crises.
Game-changing potential.
Absolutely. Imagine the impact of safe, minimally invasive surgery becoming available in places that currently have very limited options. Less infection risk, faster recovery, less strain on resources. It's about democratizing access to modern surgical care.
So the future isn't just about making current tech a bit better. It's about these fundamental shifts, AI, robotics, accessibility, promising even greater precision, safety, and a truly global reach that will keep redefining surgery. It's definitely an exciting time to be in this field. Hashtag tag outro. So let's bring it all together. What does this whole incredible journey mean for you operating today?
We've traced this amazing odyssey. From Bozzini's candle, Kelling's dog experiment, Jacobi's courage. Through Maury's leap, the video revolution, all the way to AI and robotics. It's been a story of incredible vision, facing down ridicule, relentless innovation, and always, ultimately, aiming for better patient outcomes.
Right. And every time you turn on that tower, flip on that light source, remember you're not just starting a machine. You're connecting to that whole history. You're carrying the torch passed down by generations of innovators. You're tapping into, as the sources put it so well, the distilled dream of 2 centuries to see inside without cutting wide. It's a connection to that spirit of trying to do better, less invasively.
The laparoscopic machine truly is the eye of surgery's future. And as surgeons, you're not just users of these tools. You're part of their continued evolution. So maybe think about that. What's your role in shaping the next chapter? How will your experiences, your needs, your innovations push this technology forward? How will this ever-evolving eye keep changing how we operate, pushing boundaries, and ultimately benefiting the patients you care for? The journey's definitely not over. You're right there, driving it forward.